Okay, I think we're ready to start. As I said before, the title of this session is Telemedicine and 112 Case Study, and it is indeed a great privilege to introduce to you Dr. Raed Arafat, Secretary of State at the Ministry of Internal Affairs, as head of the Department of Emergency Situations and responsible for civil protection and rescue, as well as emergency medical care in the hospital field and emergency departments. But that's just what my notes say. Let me say a few things without notes, because in reality, Dr. Arafat is an emergency pre-hospital care doctor above all. And I think the way to describe it is if I show up on the screen famous article a long time ago, 2012, taking care of his adopted country, one emergency at a time. I have to say that the New York Times were not being accurate, because it's not only taking care of his adopted country, it's taking care of Europe, if I may say so, by not only being active within Romania, but also being active within Europe. So, Dr. Arafat, the floor is yours. Telemedicine and 112 case study.
Thank you. As usual, you are full of surprises. So, could we go to the presentation, please? It is the presentation that we... Yeah. Okay. Thank you. So, telemedicine, for those who don't know what it means to have a doctor as a genie at a distance. You just push the button and he appears and he gives you advice. And this is very important when you are dealing with emergencies and you are not a doctor, you are a firefighter, or you are a nurse who needs more advice or who needs more experienced decisions. What I'm going to start with is a very short film. I'm sorry for the beginning because it talks about me, but it is a film which was shown on National Geographic. And it explains very shortly the system we have in Romania. So please follow up this one.
So, this is one of the new emergency departments in Bucharest.
Before 1990, too many patients were dying on their way to hospital. But then, Dr. Raed Arafat created the Mobile Emergency Service for Resuscitation and Extrication, SMERD for short. And now, Romania has one of the most extensive telemedicine networks in the world.
Here what you have is this video system which allows us to see and talk to other hospitals, up to maybe 150-200 kilometers away. So we control the camera and we can see as small details as even the pupils. And then you have here the pre-hospital system, where you can get ECGs and you can get data from the ambulances. The real-time transmission system. So what we were seeing was exactly what was happening there.
Ambulances equipped with defibrillators can transmit vital signs in real time. And some can video stream images to the control center, enabling life-saving care by doctors before they even reach the hospital.
So what can you read already just looking at that?
The patient seems to have, just by viewing the EKG, acute myocardial infarction. Right now, I have to speak with my team there, so I can find out if the patient has chest pain.
Based on this virtual assessment, the team in the ER will be prepped with all the available information for the patient's arrival.
For us in Romania, the system starts from the 112 call center. It goes down to the dispatching and the telemedicine, as you have seen. It goes through to the emergency department, which is considered part of the system. If the emergency department is not integrated and not well prepared for this, the disaster will become in the emergency department. In order to give the people safety and security, it is using a lot of technology. It is a smart system. It is a system which is using every possibility it has.
Yeah, that was a film about smart cities which was run by National Geographic, but it explained very well what we are doing in telemedicine. It was shown in Bucharest, but in fact this is in the whole country, the system. And each ambulance, each type B ambulance which has a nurse or a paramedic on it has the capability to transmit telemedical data. So in the pre-hospital care, this is, for example, the image of the Bucharest Fire Department dispatch. And this is a doctor who is on duty in the Bucharest Fire Department dispatch. This doctor's duty is to coordinate the teams and to do the telemedical work inside the dispatch. And they receive about 22 to 26,000 transmissions a year in this dispatch. From cases which they identify in them myocardial infarctions, and why it was very important. Before, we used, when the ambulance arrives, chest pain, go to the nearest hospital. Okay, the nearest hospital did not have a cath lab to save the patient. The patient was counter time. They have 90 minutes to get their coronary open again. So then that hospital would call a second ambulance and they would move the patient to the cath lab in another hospital. Now, when they receive the data, and they decide it's a myocardial infarction, the patient is sent directly to the cath lab, which is on duty. They don't stop anymore at the nearest hospital. If it is in the rural area, we may send a helicopter there. We don't wait for an ambulance to drive the patient 40 kilometers. And this all shortens the time to deal with patients. If that hospital where it is in their county doesn't have a cath lab, we may divert the ambulance to another hospital which has a cath lab. So this is including telemedicine within the dispatching inside the 112 system. Of course, it is not sufficient to have the medical data. We thought that we need more to know more about what is happening. So we started, the testing started in 2003. In 2008, we already decided to have it on all our ambulances. So there are about 1,400 ambulances that have the system. So if we see the video streaming of the system, you will understand why it becomes even better. This is a real case that you are seeing here. It is 60 kilometers away from the nearest hospital. It's somewhere in a village, and this is a fire department ambulance with EMTs from the fire department doing resuscitation. And they are waiting also for an advanced medical team to arrive, which may take time. Even if it is coming by helicopter, it will take time. So the doctor, we are showing a different angle here, but the doctor can see exactly what is happening when he's watching also the resuscitation. This led us to take the decision to teach the firefighters to put IV lines and to have the permission to give certain drugs based on the order of the physician. And the physician is responsible for that. So they can give adrenaline, which is very important for resuscitation. They can give other drugs if the doctor decides that while they are doing the resuscitation. So we are buying time for the patient with telemedicine. It is not just dispatching, it is not just sending a certain team, it's coordinating until the last minute. When the doctor or the advanced team arrives, then they take over and the dispatch doctor stops following up the case and deal with other issues. Here you can see the defibrillation and so on, all. Yeah. So, the video streaming can help us also in trauma evaluation. So it is not only cardiac cases. If it is an accident, it is useful to see what is happening for the fire department, for the medical service, and for those who are deciding to dispatch more resources. It is even when we send ambulances to back up firefighters, it can show at the dispatch what is evolving on the scene and what is happening to the other colleagues in the dispatch from the fire department. The next part of the system is the between the hospitals. And here we have 3 hubs. This completes the system. The 3 hubs are connected to nearly 94 hospitals. And the 3 hubs are university hospitals, and they are connected to emergency rooms. And this allows us to follow up certain cases and to decide on sending helicopters or not. So when a small hospital says, I need a helicopter to transfer a patient or a mobile intensive care unit, If they get in contact with one of these university hospitals, we can evaluate the case and decide which is the best mean to transport the patient. Sometimes they say we need an ambulance, and when we see the patient, we say no, we are sending the helicopter, and sometimes it's vice versa. This is one of the control rooms for inter-hospital. For example, this hospital, which this is its control room, this hospital here is 120 kilometers away from it. This hospital is over 200 kilometers away from it. And they can control the cameras and everything which is happening. This is 150 kilometers away. They are looking at the ultrasound of the case to decide where to send the case. It was an ultrasound to see if it is malformation of the heart, and based on this, they would send the case to a certain center. And this is the doctor looking at the heart and so on. This is another situation. This is a city where there was a case. These here in the red are a team which are led by a resident, not a specialist physician. So they are having a backup from a specialist physician, which is talking to them, looking at the case and advising the resident what to do. In the meantime, they are working now. You will see they will start intubating. I'm sorry, the pictures are strong, but they show in fact what happens. The movement of the camera is done on the remote side, and now they are preparing to intubate the patient, which is with severe head trauma, and the helicopter is already on its way. We are buying time. Instead of waiting for the physician on the helicopter to do this work is being done by the resident and the team, which they are trained to do it. We know what is happening on the scene. They are in contact with the doctor in the helicopter if anything happens, and we are shortening time. This patient proved to have what we call epidural hematoma, which is a clot which needs to be evacuated urgently in a neurosurgical department. And the hospital he was in, it didn't have any neurosurgery. It was a small town hospital. So you see now they are giving the drugs. They discussed with the doctor, which is in the remote, in the hub center. The patient will go immediately to sleep, and they will intubate the patient whilst the doctor is following up. This is very important from the point of view of working at a distance. And I'm going. Yeah, you see the patient now is under anesthesia, he was evaluated, and they will start the intubation. The equipment we have now, we are trying even to include what we call video laryngoscopes, where you can see even what the doctor there is seeing. So these things have a lot of chance to develop even to much more advanced technology. Okay, now in rural areas we started developing, but this is going harder. In emergency medicine it works easy. When you start working with family practitioners and so on, it is harder to convince them to use the system, but this is being used in the Delta area, where the GPs contact the ambulatory of the county hospital, which is far. It is separated by water, by 1 hour, 2 hours of boat ride, and this they can avoid patients moving for simple cases. If they have critical cases, it is a helicopter which should go, or fast boats that we have. Now, this is, of course, is being tested now in several rural areas. Now, to end the presentation, we started this project, of course. Here it is talking about future. We started now in all ambulances, we interconnected them on a national database system. So the alerts and everything is going into tablets, they report there, we can see what they are doing, and this system is going to replace paper, so we are going completely for paper-free system within the next 1 to 2 months. This is the last thing I'm going to show. It's a film done by NATO. So we have talked about telemedicine with 112, what we do with individual cases, what we do between hospitals. We ran a project in Romania together with some partners, and we developed a concept of working with telemedicine in disasters. When it is a big disaster, to go with systems that can allow the people in remote areas to talk to people who are specialized thousands of kilometers away, using satellite communications this time. And I will let this film to show this is an exercise in Ukraine, and here you will see also a similar telemedicine system in the States, which it will show it. It's again one.
This is what a telemedicine field tent looks like. And this is what it looks like when the President of Ukraine and the NATO Secretary General come to visit.
With NATO is to create a multinational capacity for disaster response, for civilian response as well. So we can have portable kits that are on that are equipped.
By any measure, Ukraine 2015 was a big exercise. CBRN teams faced real chemical hazards underground. Firefighters had to rescue people trapped at height, while search and rescue teams with their sniffer dogs through their faces, they had to dig through reinforced concrete to reach those trapped inside the building. Patients presented with a variety of trauma and crush injuries. In all, there were 1,100 people from more than 25 nations taking part, and this was the first time telemedicine had been tested during such an exercise. Earlier in the year, the NATO telemedicine team travelled to Sioux Falls in the US to see a virtual hospital. In the world of telemedicine, this is what an intensive care unit, an ICU, looks like.
So that surface area is about just shy of 600,000 square miles, or about the size of France and Germany combined, is what we run out of this operation.
Through the Science for Peace and Security program, NATO is supporting the development of a global telemedicine system that could help countries during times of disaster by connecting doctors around the world.
This virtual center is tied to 130 different emergency departments across the upper Midwest.
But it's one thing to see a demonstration in a car park, quite another to test the equipment during a massive exercise on a military training ground. As well as checking that the system can send patient biometric data around the world in real time, the kit needs to be easy to use for doctors in the field.
So I have a 19-year-old gentleman who was involved in an accident. He was injured. He has a fracture on the left side of his face. And when I was checking his eyes early on, his pupils did not react as rapidly as I expected them to. I mean, some of that could be from just the ambient lighting, but I would like a second opinion just to make sure that this response is adequate.
The team also need to check the communications, how satellite compares to the preferred option of 2G or 3G phone links. This is where the experts from the Special Communication Service of Romania come in.
We've set up the link to Cristi Boeriu, a doctor in Târgu-Mureș. Right now the field kit is online and ready to call the doctor, and it took 17 minutes from the moment we got out of the truck.
Certainly, there was no shortage of observers during the exercise.
We connected to Romania, we connected to Finland, we sent an ECG tracing to both doctors. We also sent an ultrasound to the doctor in Finland. So just wanted to get his impression of what did he think about the telemedicine system.
Okay, so to resume or to have just a conclusion, I think that the future, when we are looking at 112 is not just a simple call number for us. It is becoming more of a system. It's a system of getting the call, localizing the patient, dispatching. In the future, we are looking, of course, at how to make things much easier, not to separate the 112 call from the dispatching and have things going even in a more integrated manner. We succeeded in Romania in the last years to bring the fire and the medical all together in the same dispatches. Now in Bucharest we have a beautiful new building which costed 20 million euros, and we are still fighting the ambulance service to move there, but they will move, I hope this year, together with the fire department to work together. So the technology like this, telemedicine, AML, all this, the only thing it is doing, it is bringing us nearer and nearer to the patient, and it is making our work much easier, and it is helping us to save lives. Now today, I don't know how many of you know that it is the International Health Day, it's the World Health Day. So for those who work in emergency medical services, just congratulations for the International Day. Thank you.
Thank you. Thank you, Dr. Arafat. Okay, a couple of questions from the audience. We do have some minutes. Yes. Coming up still.
Thank you, Dr. Arafat. A lovely presentation.
Can we...
The mic is not working.
Is the catch box on? Okay. Let's go low tech.
Thank you, Doctor. A lovely presentation, and I'd love to see that facility available to us in London. My one question to you, when all those decisions are being made by doctors, would it be cheaper to have paramedics or advanced paramedics as a link in the chain, making some of the easier decisions?
Well, using doctors and paramedics is different approaches. We have a pyramid. Our base of pyramid is EMTs and firefighters. We have then the nurses of the ambulance service. We have GPs who do also house visits. They are not doing also only emergencies. And then we have doctors going out of the emergency department. It's an issue of policy. Because training paramedics takes some way. If you can train the doctors who are doing the emergency department also to go out, I think this is not a wrong thing. Having paramedics to completely replace doctors, I'm not one of those who is in favor of this. So I think it's a complementary system. But even if you have paramedics, you still need telemedicine. Because the decision finally, if it is something very critical and so on, sometimes you need discussions to look at it. And that is either the emergency physician or the cardiologist or so on. So Israel, for example, after a visit they did to Romania, they took over the idea and now they have it all over. And they have a physician all the time in the dispatch looking nationally at transmissions. But they faced an issue. At the beginning, people didn't want to push the button, which we faced it in Romania. They refused to push the button because they thought, we know better. We've done this for 20 years, why do they want now to push their nose in? So the solution that Israelis found with the company, and I think that we will soon adopt this in Romania, is to ask them that the machine starts transmitting automatically. So when you push the button, it starts transmitting. You can cut off the transmission if you think in the dispatch you don't need it, but if you observe anything, you go into connection with the team and you start talking to them. And you start asking for more information. I think that the future will bring all these types of professions together, the paramedics, the EMTs, the doctors, and so on, to work in a more complementary way. Yes, the telemedicine may reduce the use of doctors in the pre-hospital. And this is one of its real advantages. It says, if we see a patient 30 kilometers away that he's okay, then we say, okay, the patient is fine, transport the patient, we are not going to send you any advanced medical team, and then the fire department will do it. So, and I have a case study, if you allow me. We had a case which shows exactly what it means. When we started in 2003, that was one of our first cases. Patient 24 kilometers away, an EMT team from the fire department gets to him, and they say he's tachycardic, they say that he is perspirated and so on, and they did the transmission, and it was a ventricular tachycardia, which is very dangerous, as you know, it is with wide complexes and so on. So we saw this in the dispatch, in the hospital, and the immediate decision was, I was there, I went to the helicopter, took off there, it was a 6-minute flight, but it was about a 30-minute drive. So got to them, one of my colleagues told them what to prepare for the patient was shocked. He came back with us in the helicopter, alive and stable. I am sure that if we would have had not the telemedicine, we may have told them, okay, bring the patient in, we will meet you on the way, or we will lose more time, and from ventricular tachycardia, you know that it is very fast, you go to cardiac arrest. So this is what telemedicine does.
Okay, last question there.
Thank you. My name is Ružická. I am intubating my patients in the region of Pilsen and Karlsbad in West Bohemia, and so I'm from Czech Republic. I thank you very much for this beautiful lecture. I understand completely that you save physicians because my country, I'm sure, as Romania and other not paramedic-based EENA systems, there are lack of physicians. I'm not so sure that we can make a ultrasound telemedically, because to find exact position of probe in echocardiography, maybe I don't know, I just know.
It is very easy. You teach technicians. But the person who was doing the ultrasound on the other side and holding the probe was also a doctor. And she was trained in ultrasound taking, but she was not trained on children. And she was not trained for that particular case, and she requested the help. So, at the same time, it is very easy, and it is being used to train a nurse or even paramedic or EMT on using the probe exactly on how to put it and so on, so that they transmit the images.
I don't want to argue with you, of course, but
so
just my question. How many physicians, which percentage of physicians you can save by this system?
Well, in Bucharest, for example, for every 100 cases, our last study was for every 100 cases we have by the fire department, only 7 get a doctor on the scene. And usually, so it is, before we used to send doctors much more. So that means 7% of our cases now in the field with the fire department need to send a doctor back up. And it is very rare that we send the doctor first, except if we know it is something very serious from the beginning. So if the first response teams, which arrives in a few minutes, gives us the data and we think that we need to send the doctor, we will send. But if sending the doctor is longer than evacuating the patient to the nearest emergency department, then we ask the team to evacuate the patient to the nearest emergency department. So it's a mixture of decisions that we take.
Thank you very much. Indeed, a very interesting presentation. I would like now to invite participants to go for coffee, which is good news. But return by 11:05 here for the next plenary session